report. And you're welcome to get more information about the doctor and about prostate oncology specialists at www.prostateoncology.com. A little bit about, if you're new to Prostate Forum, what we do here. We have monthly presentations led by top experts in their fields. So it allows you to get to know your potential treatment professionals. Information from when to start detection, PSA, to mitigating post-surgical effects such as incontinence and ED. We conduct Zoom meetings of our active surveillance newly diagnosed group and advanced metastatic cancer group, provide information, discussion, and hope. We don't provide medical advice in our groups. We share personal experiences. Both groups are co-led by Dr. Charles Metzger, MD, and Ira Caggett. Our website, which we encourage you to visit, is www.prostateforum.org with information and a link to our video library. By the way, this is being recorded, and we will have this posted very soon after the meeting. All services are free of charge, but we do ask for donations. Donations are entirely voluntary, and we send out newsletters most Saturday evenings by mail. Those newsletters are written by Dr. Metz. This is how we run the meeting. Dr. Scholz will present for about an hour. We will take your questions via the chat box after the doctor concludes. So feel free to put your questions in the chat box and I will read them. If there's a problem with clarifying the question, we'll ask you kind of to open your mic and clarify the question. In the meantime, we ask that you please mute yourself so we don't get a lot of background noises. To send a donation, you can go to PayPal via www.prostateforum.org/donate, or here's our address. If you don't get any of this now, we have this up on our website at prostateforum.org. If you want to help us, we're all working from home. Contact us at prostateforumoc@gmail.com. Tell us you want to volunteer, leave your phone number. We will be delighted to talk to you. And I think now, without further ado, Dr. Scholz, a prostate oncology specialist.
Good evening, everybody. I'm going to be talking to you tonight about a tricky area of prostate cancer management, what we call intermediate risk or newly diagnosed intermediate risk. How do we put the slides today? So I wrote a book about prostate cancer called The Key to... that's not my kid. I wrote a book called The Key to Prostate Cancer, and we subdivided prostate cancer to 5 major groups. Prostate cancer is a huge topic, and stage prostate cancer, and so
you keep cutting out. Your audio's off.
For some reason, our computer is saying we're being muted by the host. All right.
I'm trying to get some of these other folks muted here.
Okay. Hopefully we're all set. So we'll be talking specifically about intermediate risk prostate cancer and what it is and how to treat it, and the treatments that are best and provide the best cure rates and the lowest incidence of bad side effects. So we'll just jump right into it. How do I advance the
Recording in progress.
There we go. Okay. All right. So when you talk about newly diagnosed prostate cancer, it's generally broken down into 3 groups: low, intermediate, and high risk. We call them Sky, Teal, and Azure. And the reason it's interesting to talk about the Teal stage, the intermediate risk stage, is because that's the transition between the most desirable treatment, which is to do nothing, simply do active surveillance, which is certainly feasible. Probably 100,000 of the 200,000 men diagnosed every year are eligible to do active surveillance. Sadly, only about 50,000 out of the 100,000 who are eligible are actually given the option of active surveillance. Many are frightened into unnecessary therapy for a harmless condition. This is usually characterized by people who have PSA levels under 10 and Gleason scores on their biopsy that are 6 or less. So that's pretty straightforward. Simply monitoring is the best. If you go to the other extreme, the high risk category, we call it Azure, people with Gleason 8s, people who have PSAs over 20, scans that show invasion into the seminal vesicles or lymph nodes of the pelvis. These people need maximal therapy, and that also is pretty straightforward. Any treatment that has anti-cancer efficacy that is not excessively toxic should be implemented to optimize cure rates. So the, why does it keep?
I'm sorry, doctor. I hit you by mistake.
All right, we'll try and unmute it. There we
I
go.
was trying to let somebody in here. I'm sorry.
Recording in.
Okay, so so for me, if we were talking about the low risk Sky group, or we're talking about the high risk Azure group, it'd be very easy because the type of prostate cancer we're talking about is clearly so low grade it doesn't need treatment, or clearly so high grade that it needs maximal treatment. So the intermediate risk category is the most complex, where you have people with favorable intermediate risk that you can watch, or you can have unfavorable intermediate risk that you would want to treat with maximal therapy, and then you have transition in between those extremes. So when we're talking about Teal or intermediate risk, you see on the slide here that we're talking about generally people that have a Gleason 7, a PSA of 10 to 20, or if there's a lump in the prostate, it's of modest size. It's not a big all-encompassing mass that that extends into the seminal vesicles. So is there a way to move all this? How do we move it? Oh, yeah, there we go. Is there a way to get here? Sorry for the delay. We're not technically savvy here. Is there a way? I can't see my own if I'm positioned in the. There we go. Perfect. Okay. So all this is sort of obvious that prostate cancer comes in many forms, and a lot of people have trouble dealing with the fact that something that's called one thing, prostate cancer, is actually many different diseases. And of course, it's not only are there different stages of disease, but there are actually different types of cancer. So something that's low grade is a different condition than something that's high grade. Something that's a Gleason 6 is a completely different entity compared to Gleason 8. So it's different as, say, someone who has a basal cell cancer on his skin as opposed to a melanoma on their skin. They're both skin cancers, but they're not the same thing. So we have to know what we're treating before we can recognize what the optimal treatment is, because we want to give just enough treatment to get the job done without overdoing it and incurring a lot of unnecessary toxicity. We're talking about the area where the prostate is a very sensitive area of the body, and it's very easy to mess up urinary function, sexual function, and whatnot if excess treatment is being administered. So we don't want to be emotional about this. We want to be very dispassionate. We want to base our decisions on studies and experience that is relevant to each stage of the disease. And so when we're talking about intermediate risk prostate cancer, we're not talking about the treatments for low risk disease or high risk disease. We're just talking about this segment of prostate cancer. So why is it a struggle sometimes to find the right treatment for prostate cancer? Well, I've already alluded to the fact that it's a vast field and there's a lot to be learned. I've had patients, when it's all said and done, after deciding what to do, relate to me that there was more pain and effort in the process of deciding what to do than there was in actually undergoing the treatment. The treatment itself had less side effects than the process of figuring out what the right treatment was. So why do we have these problems? Why is it so complex? Well, many types of prostate cancer, but we also have sort of a strange situation where what we call proceduralists, that's like radiation doctors and surgeons, radiation therapists and urologists, are making the primary decisions about what to do. And everyone knows that they're going to have biases for what they particularly specialize in. So that confuses things. People come into this field suddenly with their PSAs up, they get a biopsy, and now they're talking to a surgeon, not realizing that that is an inherently slanted view. So that's one problem. The other problem is that there's not only trying to survive the illness. Most people come to the prostate cancer world thinking, with cancer, my one and only goal is to live. And I don't mean to minimize the importance of that goal. The thing is, with intermediate risk prostate cancer, what we're talking about tonight, that it's really easy to live. There's relatively few people with intermediate risk prostate cancer that will ever die of it at all. And practically none of them will die of it within 10 years. So it's easy to live. Therefore, it's reasonable to set a higher goal and to try not only live, but to live with a good quality of life. And so who decides what a good quality of life is? Well, the patient himself has to decide what the good quality of life is. And to make an educated decision about what a good quality of life is, the patient has to understand what the heck's going on. They have to study about prostate cancer treatment options and then start to project themselves into situations where they may have impotence or incontinence, and what it would be like to live with that for many, many years. So a third problem, of course, is that the one thing that matters in prostate cancer treatment is whether or not anything gets outside the prostate gland. Prostate cancer that stays inside the prostate, which is what Gleason 6 does, never spreads, never been shown to spread, is harmless. The prostate can tolerate an enlarging tumor in the gland quite easily. There's plenty of space in the prostate for tumors to grow inside the prostate. There's some vague concerns that bigger tumors are more likely to spread than smaller tumors. But if it's truly a Gleason 6, it doesn't even matter how big it is. So the issue is, of course, when you're sampling tumors with needles, you don't know if you've got every detail about what's going on in those tumors. But the issue then is, what's the chances of it having something break free from the mother tumor, spread around into a lymph node or on the bones, which totally changes the complexion of what we're dealing with. Before, we had a harmless condition that was patiently sitting in the prostate, but in certain individuals, if it spreads into the lymph nodes or bones, now we're dealing with something that could become life-threatening. Not necessarily life-threatening like other cancers. Other cancers, if there's metastasis in the bones or the lymph nodes, often it means that it's game over. And those unfortunate individuals with stomach cancers and lung cancers are really ultimately destined to die, oftentimes within a relatively short period of time, within 3 to 18 months. Dreadful situation. Not prostate cancer. A person who has spread into the lymph nodes can easily live for 10 to 20 years. In fact, most people will, and many will end up dying of old age, not from cancer. So we're not covering that stage of disease, but the point is the risk of spread outside the gland is what defines prostate cancer. And that's a bit of an abstraction, trying to predict the possibility of something happening and acting on that basis. Now, we're going to talk a little bit about PSMA PET scans tonight, which simplify this to a great degree. And I've characterized PSMA PET scans as possibly the biggest breakthrough in the field of prostate cancer since the discovery of PSA. So, so we'll go into how determining the risk of spread can be simplified with these new PSMA PET scans. All right, so let's just make sure we all understand what a metastasis is. Metastasis is not something that spreads through the edge of the prostate. People think that if it gets outside the capsule of the prostate, that means it's spread and it's going to cause, some sort of, a future metastasis. That's just not true. Metastasis means that something gets either into the lymph or the bloodstream, floats around and lands in a distant place like a lymph node or the bone, and then starts growing. That requires specific types of cancer cells. For instance, Gleason 6 grade cannot do that. That just doesn't happen. But they can push up against the edge of the gland. They can cause some swelling. They can even break into the capsule. And this used to be a real big deal. This still is a big deal for the surgeons because they're forced to cut right on the edge of the gland. And when they cut the prostate out, they end up leaving cancer behind. This doesn't happen with radiation, but it does happen with surgery. And that is why there's still this sense of, oh, we don't want to get out the edge of the gland. But let's be very clear. Having something break through the edge of the gland has none of the frightening implications of something spreading into a lymph node or the bones. It's a different type of cancer. Something simply spreads out the edge of the prostate is easily treated and cured with modern radiation. So the other thing let's make clear is that there are many different, hundreds and hundreds of different types of cancers. And I'm not talking about variants of prostate cancer. I'm talking about cancers that start in other organs like the bone or the liver, lung, and whatnot. Prostate cancer that spreads to the lung is not lung cancer. Prostate cancer that spreads to the bones is not bone cancer. There are bone cancers and there are lung cancers, and they're dramatically more dangerous and deadly than prostate cancer is. Even if prostate cancer gets to the lung, it's only probably 5% as dangerous as lung cancer that started in the lung. So don't confuse the two. Lung cancer, a spot of cancer from prostate cancer that lands in the lung is nowhere near as dangerous as lung cancer. So how can these metastatic sites, if something gets outside, how do metastases hurt people? Well, basically they become so extensive at some point because they keep replicating and spreading that the organ starts to fail. So people can develop bone marrow failure. Your bone marrow makes your red cells, your immune system, the normal clotting elements. So people can actually die of failure of those functions. Or if it gets into the liver, people can die of liver failure. So metastases are what lead to people dying of cancer, not something that's growing in the prostate. That does not lead to people getting sick or dying of prostate cancer. So I want to talk a little bit about the concept of micrometastasis, and this is an older presentation. It needs to be updated for the advent of new PSMA PET scans, which we'll sort of talk about as we go along. So micrometastasis were called micrometastasis because they're invisible on historical standard scans, like bone scans, like CAT scans, like MRIs. These types of scanning technologies can only pick up spots of cancer that are about a ½ inch across, which is about 1 billion cancer cells. Anything smaller than that is called a micrometastasis because it's not picked up on a scan. They're not really that micro, but with the pre-existing technology before the advent of PSMA PET scans, these many chunks of cancer were invisible. And so that means we had to take that into account. We had to just deal with the fact that we had suboptimal scanning, and we had to deal with the risk of chunks of cancer being out and about in the body, and just take precautions. The possibility that it'd be there. If the Gleason score is higher, the PSA is higher, we would take additional precautions. So those were called micrometastases. PSMA PET scans now can detect spots of cancer down to about 2 millimeters, which is radically smaller than what we could detect with CAT scans, bone scans. And so micrometastasis meant that we had to make allowances on the theoretical possibility of cancer being outside. Whereas now with PSMA PET scans, which are now covered by Medicare and widely available in PET scan centers across the country, we can actually determine if such metastatic sites are present or not. We're no longer guessing. We're actually looking at actual facts. So this has a couple implications. One implication, of course, is that if there's nothing out there, the precautions that historically have been necessary, like extended courses of hormone therapy, empiric radiation therapy to pelvic lymph nodes, is no longer necessary. So it allows us to tone down a lot of the intensity of treatment in people that have a staging PSMA PET scan that does not show any metastasis. Then on the other extreme, if PSMA PET scans do pick up metastasis, then we know unequivocally that that individual has a biologic variant of prostate cancer that can spread through the bloodstream to distant parts of the body and could become deadly. Those individuals need maximal treatment, not only radiation to the known spot of cancer, but also prophylactic systemic therapy with things like chemotherapy and extended hormone therapy. So instead of dealing with uncertainties and possibilities, now because of PSMA PET scans, we're looking at realities of the presence or absence of any metastatic disease. So let's go back to now our intermediate category. We're talking about Gleason 7 cancers. They may have PSAs as high as 20 in some cases. And reiterate that most of these people are, not most, practically all of these people are going to live normal life expectancies. Most will be cured with the initial therapy. So preserving quality of life is essential. And of course, we want to not have to, come back and have to treat it all over again. It's just as unpleasant the second time as it is the first time. The reason that we don't fear mortality is because cure rates are very high. And we have, with most cases, if someone has a relapse, that there'll be a second chance to cure it. We'll be able to detect where the cancer is at an early stage and treat it aggressively. You may even have a third chance to cure it if you don't do this successfully on the second go around. And of course, the people that have recurrent cancers that aren't being cured still live for 10 to 20 years or longer. And we're discovering new treatments at a furious pace. So historically, as I mentioned before, we rely upon bone scans and CAT scans and MRIs. In my opinion now in 2022, these are all antiquated. I don't order them at all anymore. We do occasionally, not occasionally, we regularly do MRIs for people who are on active surveillance and we're following shadows inside the prostate. So we'll do high quality 3 Tesla multiparametric MRIs. But we don't go searching around the body anymore with bone scans or CAT scans or MRIs because compared to a PSMA PET scan, they're worthless. These things are now antiquated. There's no point in doing them. And as I shared before, if PSMA PET scan shows metastatic disease, then we turn up the intensity of treatment. If a PSMA PET scan shows no metastatic disease, then we cut back on the intensity of treatment and just treat the spot in the prostate alone if a treatment is necessary. So you can kind of break the intermediate risk category down into 3 broad categories. And this is historical pre-PSMA data. So you have the people with the very favorable intermediate risk, kind of like low risk, and the chances of any metastasis being present is almost 0. You don't even need a PSMA PET scan. To people that have, Gleason 4+3s with PSAs in the high teens that could have micrometastatic disease in up to 50% of cases. So it's a very broad ranging category. So specifically, how do you divide these categories up? Well, it's dependent on the Gleason score and it's dependent on the extent of disease in the prostate. And of course, ultimately, whether PSMA PET scan shows any disease spread outside the gland or not. So Gleason 3+4 is the lower risk variant of teal. And the amount of grade 4 needs to be stipulated. I still see pathology reports that'll have 3+4. The pathologist doesn't say what percentage of the tumor is grade 4. This is exceedingly important, because if there's only 10 to 20% grade 4, these people have very indolent low-grade processes that can be managed with active surveillance. They can be treated like a 3+3. So active surveillance is, in my opinion, is one of the more attractive options, because you're not risking the dangers of treatment. We'll go through the treatment options here in a minute and show what those dangers are. So if you look at, as the risk goes up from low teal to high teal, or to basic teal and high teal, we got them sort of reversed here. You say at the other extreme, the high teal are where people have a Gleason 4+3, the more grade 4 than 3, and then they have a large volume of tumor inside the gland. These people are going to be at higher risk for something spreading outside the gland, and these are the individuals that do need to have a PSMA PET scan. One ancillary benefit of PSMA PET scans also that comes up, because we'll be talking just a little bit about focal therapy in a minute, is that it also registers whether there's unilateral or bilateral disease inside the prostate, and whether the candidates would be appropriate for treatment with something just to part of the prostate rather than the whole prostate, which reduces the risk of erection problems in these individuals. So this summarizes then, if we talk about the favorable types of teal or intermediate risk, that we're thinking about doing active surveillance. If we think about the unfavorable types of intermediate risk, we're talking about definitive therapy to the prostate. Usually it'll be some sort, we would recommend some sort of a radioactive seed implant, maybe some IMRT to the pelvic lymph nodes, and a course of hormone therapy. We call it testosterone inactivating pharmaceuticals, or TIP. So that's the spectrum of treatments for intermediate risk, can range from no treatment at all to combination therapy. And there is an intermediate zone where someone would just have radiation treatment, maybe with a seed implant, just to either a section of the prostate or the whole prostate, which we would call the basic teal category. It's halfway between low and high. So when we think about doing active surveillance, it's not like wow, we're thrilled to do active surveillance. It's just that it's less toxic than the other options. The disadvantages of active surveillance are, of course, more doctor visits. We're talking about living with some uncertainty about the possibility of the cancer growing or changing. And so those issues are some of the negatives. Some of the positives are the possibility of by postponing therapy, treatments will improve. We've certainly seen that happen over the last 10 years. And of course, avoiding the risk to urinary and sexual function, which is so commonplace with many of the treatments. So let's talk about why people would want to do active surveillance. Obviously, it's to avoid impotence, incontinence, and urinary symptoms that are unpleasant. And as we look at these three categories in people that undergo therapy, I've listed my general sense of what the risk is of having these problems when you undergo these different treatments. For instance, some sort of a focal treatment, I'll describe what I mean by that, some sort of a radiation treatment, or surgery of either robotic surgery or regular surgery. So these risks range up and down depending on how old someone is. When people are older, the risks are higher. When they're younger, the risks are lower. The definition of impotence, let's take the category on your far left. Excuse me. The risk of impotence in our prostate cancer world means that you can take a handful of Viagra, a handful of Cialis, You can put yourself in the most erotic situation you can imagine, and you will not get an erection. So most of the world thinks that if you have to take Cialis or take Viagra, that means that you have impotence, but not in the prostate cancer world. When doctors quote you the risk of impotence, they're saying, no, 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 you're bathing in Viagra. You're in a very propitious situation with someone that you're very attracted to, and you're unable to get an erection. That's what we call impotence. So it's a big difference from what the world generally thinks of as impotence. It means the pills do not work. You have to give yourself a shot or perhaps have an operation to put a plastic implant to recreate the ability to get erections. Quite a big deal. So let's talk about 3 options. Now, focal treatment, meaning we treat just a section of the prostate rather than the whole prostate, lowers the risk of side effects. It's, however, not feasible in everybody because some men have bilateral cancer. They can't treat a section of the gland. They have to treat the whole gland. When people talk about treating prostate cancer, they're almost always referring to treating the whole prostate. That's the way it's been done for 40 years or longer when you go back, including surgery. And focal therapy is considered investigational, experimental. But it is quite possible to do this with modern technology. It's just not what is generally practiced. So what are the risks with focal therapy? The risks are that you won't get all the cancer. You'll have to go back and get more treatment again. The other risk is that you have a cancer on the other side that's too small to be detected, but then appears at a later date, and you end up needing more treatment for the untreated area of the gland. So these risks are very real, and finding good practitioners that know how to treat a section of the gland successfully is a challenging proposition. Everyone claims to be the best. So my experience using quality practitioners who do good surgery, good radiation, and good focal therapy, I've seen that the risk of prostate cancer related impotence, that means where Viagra and Cialis don't work, even under ideal circumstances, patients that have focal treatment, only about 1 out of 10 have difficulty getting erections after focal therapy. Maybe 1 out of 3 has difficulties after many different forms of standard radiation. You name it: proton, CyberKnife, SBRT, brachytherapy. And well over 50% of men that have surgery have serious impotence, not just right after the operation, which everyone's impotent, but I'm talking after you've given them a year or 2 to recover. 60% are still going to end up being impotent. So this is not like a close difference between focal therapy, radiation therapy, and surgery. There's a big difference in the risk of erectile dysfunction. And this is not, I have no biases. I'm not a surgeon or a radiation therapist. I'm a medical oncologist who specializes in treating prostate cancer. And we refer several hundred people every year for different types of treatment. So I'm very familiar talking to all these patients about how well their treatment worked and how well they're functioning. I'm very interested. I want to know how good the practitioner was to determine if I want to keep sending patients to that practitioner. So the other dreadful thing that happens with prostate cancer treatment is the loss of control of urinary flow, which is, we call incontinence, wearing diapers or putting pads in your underwear. And the risk of incontinence with standard forms of radiation, many different forms of radiation, or with focal therapy is truly negligible. The risk of incontinence in the hands of superstar surgeons, and we're talking about, your average 65-year-old male who's functioning well, is about 10%, 5 to 10% of such individuals will be left with permanent incontinence for the rest of their lives. Now, if you go to an average surgeon, not a fantastic surgeon, it's going to be more like 20% risk. If you go to a bad surgeon, you're looking at more like 50% risk. So, and one terrible thing that for some reason doesn't get talked about is that doesn't matter, good, bad, or indifferent surgeons, 20% of men who have had a radical prostatectomy ejaculate urine for the rest of their lives. So this is called climacturia, a really disgusting thing that doesn't get talked about. I think people are just so shocked by it, they don't even bring it up with their physicians. So these are really bad things that happen with surgery, but don't happen with focal therapy or radiation. Now, there's another phenomena called urinary bother, because this is the one area where surgery can hold its own compared to focal therapy or with radiation. Excuse me, hold its own with radiation, not focal therapy. So urinary bother after focal therapy is negligible. Urinary bother is pretty negligible as surgery, but with radiation, it's a little higher risk. And what are we talking about here? Urinary bother is where people have an increased sense of urinary urgency, or they have to get up more frequently at night to urinate. And this is a common problem right after radiation. It usually goes away after a month or two in 90 to 95% of people. But in a small percentage of people who apparently don't heal as well from radiation, long-term urinary bother can linger after radiation therapy. So these are the fears that we have to deal with in contemplating the different treatments. As you can see, my experience with surgery is pretty dreadful. And I'm not talking about bad surgeons, I'm talking about the best surgeons. All right, so if people are going to try, let's say they have a low teal, a 3+4 with relatively little 4, we want to have the pathology reviewed at a reference center to make sure that it's bona fide Gleason score. We might want to have it checked genetically for something called oncotype. I like the oncotype reports because they will examine the biopsy material and profile people according to their genetics, a large database, as to what the risk of spread is for that particular type of cancer over the next 10 years. And that's really what we're concerned about with active surveillance. What is the risk of spread? So if the risk of spread is relatively negligible, say 5% or less, that it's attractive to consider watching it and avoiding all the dreadful things that I pointed out in the previous slide. Active surveillance avoids all of these problems. So, but what's the chances of something spreading during the active surveillance period? Well, if it was a high risk, active surveillance wouldn't be popular. Active surveillance has been around for more than 15 years right now, and the risk of spread, thankfully, with properly selected people is very, very low. And that was back before we had good quality scans. We now monitor people with high resolution MRI scans of their prostate every year. And the good results with active surveillance were attained before we had such scans. People would just get periodic biopsies, which I consider to be an outdated approach now, but still popular around the United States. So how could someone, although it's very, very rare, but how could someone develop a spread of cancer while on active surveillance? And the answer is two things. One is if in the initial staging process, the biopsy that was done, oftentimes a random biopsy, showed very favorable pathology, but the needles didn't hit a higher grade spot, perhaps at the front of the gland, and such an individual harbors a higher grade cancer that was missed on the random biopsy. This problem can usually be avoided by a good quality, high resolution MRI scan of the prostate to make sure that there are no suspicious shadows that don't match up with what the biopsies have shown. And then, of course, the other thing with active surveillance is that as long as someone has a prostate, an intact prostate, they have every possibility of also developing a new higher grade cancer.
Oh.
So since that is always a risk, people have to be monitored just as women get annual mammograms. In my opinion, it's very reasonable for men on active surveillance to get annual MRIs to make sure that they're not developing a new higher grade cancer that would have the potential to spread, even though their original cancer does not. So, yes, there is a risk of some cancer spreading, although thankfully studies have shown that the risks are very, very small, and I think almost completely eliminated with modern technology. So when we do have to treat something inside the prostate, what have I tended to lean toward? I have tended to lean towards radioactive seed implants because, number one, as you can see, I like all forms of radiation much, much better than I like surgery. And I like seed implant radiation better than other forms of radiation because it's not necessary to beam the radiation through healthy tissue, through your muscles and your bones to hit the prostate, which is required with all forms of beam radiation. Because beam radiation has to be beamed through different sections of the prostate, through the body, the doctors giving that radiation have to dial the dose down lower than what a seed implant doctor can accomplish when he puts all the radiation inside the prostate. The prostate can be sacrificed. So people can crank the dose of radiation higher with seed implant radiation than they can with beam radiation. Higher dose of radiation equals greater assurance that you eradicate the cancer. So seed implant radiation is, in my opinion, the optimal way to deliver radiation therapy. There's two types of seed implant radiation, so-called permanent seeds, where little small seeds are placed in the gland and they emit radiation for a period of time and then die out. We're talking about iodine seeds, cesium seeds, palladium seeds. And then there's another type of seed implant radiation, so-called temporary seeds, where small little tubes are put temporarily into the prostate and a very high dose iridium seed is threaded down that tube into the gland and left there for a short period of time to radiate the gland, and then the whole apparatus is removed. So both of these forms of seed implant are able to deliver at least 20% higher doses of radiation than what can be achieved with any type of beam radiation, thus assuring higher cure rates. And the fact that they're putting the seeds under direct visualization into the gland, the precision in where the radiation is delivered is also, in my opinion, more accurate. And thus you have better cure rates, excuse me, and less exposure of surrounding tissues to radiation treatment. Now, this same concept, in our experience, can also be applied to focal therapy. So most radiation treatments, whether they be seed implant or beam radiation, are targeting the borders of the gland to make sure they get all the cancer. But now we have much better technology with MRIs and even PSMA PET scans to know where the cancer is and allow us to forego treating the whole prostate, but to just treat the tumor with a margin around it for safety. So focal seed implant radiation is, I think, a popular approach for people who have unilateral spots that are trying to preserve sexual function. There's going to be a lower risk of erectile dysfunction. So just to reiterate all the different treatments that are out there, we talked about focal therapy. I've listed here 4 different types of beam radiation, surgical treatments. In the old days, we used to give hormone treatments, which are very powerful, effective, reversible forms of therapy, but unfortunately don't lead to a permanent cure. So the seed implant variations are what we have relied upon most heavily to try when we're pursuing a cure for patients with newly diagnosed intermediate risk prostate cancer. So there are many ways to deliver focal therapy, not just radiation. Lasers, freezing, electrocution, so-called electroporation, high intensity focused ultrasound, and I already talked about radiation. So the problem, of course, with focal therapy is how do you're treating a fairly low grade process. So even if the doctor completely misses the target, you probably won't know about it for a year or two after the treatment. And so finding people that are truly devoted to just doing focal therapy, that have great imaging skills, have a lot of experience, it's a tricky thing to find. There's a lot of heavy duty marketing that goes on in this business. And of course, some of these therapies are not covered by insurance yet. They can be very expensive. So navigating the field of focal therapy is very tricky, but the rewards are high because the risk of erectile dysfunction, urinary problems is greatly reduced. And I've had a number of patients that have had focal therapy now over 10 years ago who are doing beautifully. They're cured and they have maintained their sexual function. The issues, one negative issue with focal therapy, of course, is these people have an intact, at least half of their prostate still in place. And so they're going to need surveillance, annual scans of the untreated prostate to make sure that a new cancer doesn't show up over their ensuing lifetime. So now when we get into patients, let's say people have a staging PSMA PET scan that shows a pelvic lymph node. We can zap those spots now with beam radiation and go for a cure. I've had patients that have had metastatic disease to the bones or the lymph nodes who were treated more than 10 years ago, who have recovered their testosterone, are still in complete remission. So people with metastatic disease from prostate cancer can be cured, and every attempt should be made to cure them. This is not something to give up on. The general thought is that you need to be aggressive in pursuing metastatic disease. You need someone who has 5 or fewer metastatic sites, and the fewer the better. But it's a combination approach where the spots of cancer are all radiated, and systemic therapy with hormone treatments for 18 to 24 months, and treatment with some form of chemotherapy is also discussed as well, medicines like Taxotere. So in summary then, and I know we've covered a lot really quickly, we can take this up more in the question and answers. We want to define accurately what we are treating. There are many types of intermediate risk prostate cancer. They're not all the same. It's dependent on how much grade 4 is present. It's dependent on if you have a genetic test such as an oncotype to determine the risk of the cancer spread. And of course, it's dependent on a PSMA PET scan that doesn't show any metastatic sites. People that are trying to navigate this situation need to be well informed about what their priorities are. If they're no longer sexually active, maybe going to all the trouble of doing focal therapy is not worth it. Simply treat the whole prostate. On the other hand, if people are still sexually active and prioritize the ability to have normal erections, focal therapy is a very attractive way to minimize the risk of getting erectile dysfunction. And then when seeking counsel for what to do, please continue to be aware of who you're talking to. If you're talking to a surgeon, he's smart enough to refrain from the hard sell and screaming at you that surgery is best, at least most of them are, and will invariably try and position himself as your friend and your helper and a dispassionate bystander, which is just not true. Surgical training is so intense that surgeons who are the skilled urologists that exist are in love with doing surgery. They're pursuing their life passion. So they will always have a bias towards surgery. And we have to say the same thing for radiation therapists, although radiation therapists are a little more bashful because they get a lot of their referrals from surgeons and they don't like offending their referral sources. So be aware of the fact that the people that are giving advice about what to do have a conflict of interest. So with that, I think we'll call it quits and start to take some questions.
Dr. Metzger, would you like to start us off? You're muted. If you put your space bar down, you'll unmute. There you go.
There we go. Dr. Scholz, thank you very much. You've been a voice of reason in our business for a long time. I'm a retired surgeon, so I'll probably, as I mentioned before, go to hell for saying this, but you brought some reason to the entire process. I have a couple comments, however, I hope you don't mind. Ejaculating urine after surgery. 41 years, I never saw that, but does that mean you can't tell whether you're coming or going?
Well, I think a lot of it is not talked about. I think men are so embarrassed, and you're well aware the treatments for climacturia are dismal. There's really no good treatment.
There's no good treatment, no.
So it's just a disgusting thing that no one really wants to talk about.
Yeah, I love the idea of the oncocyte report that's being underutilized. I think it gives you a lot of credibility for what you're proposing as active surveillance. What do you think about the micro DNA liquid biopsy? Is there any promise for that?
Well, I don't think it has much utility in this stage cancer, but we use it all the time in men that have more advanced stages of cancer. I think what you're referring to, of course, is that cell-free DNA can be detected in the bloodstream of people with more advanced metastatic disease. and things like Garden 360 in Foundation 1 testing, which is covered by Medicare.
Yes. It is.
And when we have people with advanced stage prostate cancer, we're always trying to discern whether the treatment that we're administering is effectively controlling the disease. This is a life and death situation. And you can actually measure the quantity of cancer DNA in the blood and then use that sequentially over time, just like you use PSA. So PSAs that are rising, we take as a negative indication that treatment is unfortunately ineffective and we need to change the treatment. And same thing with quantities of cell-free DNA that are rising, that the cancer unfortunately is not being kept in check with whatever, ongoing therapy is being administered, and probably time to change treatment.
Yeah. We just a personal note, we met on Lido Island, Newport Beach. You gave a talk to the Lido's Men's Club and then again at the book club, the bookstore on Lido Island. So I don't know if you remember that far
Oh,
back.
I remember I grew up down in Newport Beach. And so
I had shorts and flip-flops on, and I think you were a little appalled. But anyway, what are surgeons supposed to do? We have to dress the part. Anyway, thank you for a wonderful talk. It's just been great.
well, thank you.
I'll start off with questions. This from Stephen. He noticed that there's a manufacturer insert warning in finasteride advising patients that there's a 25% risk for advanced cancer patients using finasteride. And he knows a doctor that states that a patient went from active surveillance to Gleason 9. And he's associating that with the use of finasteride. Would you like to tackle that?
Yeah, it's ridiculous. The concerns about finasteride were generated 20 years ago when in sequential studies they did biopsies as a baseline, and then some patients were put on a placebo, some were put on finasteride, and then they rebiopsied them a couple years later, and they found out there was more Gleason 9 in the people that were on finasteride that were on placebo. And so they got a black box warning because the FDA said, well, maybe finasteride is causing Gleason 9. And that I think still sits on finasteride to this day. The reason that they found more Gleason 9, and it wasn't a lot more, it was statistically significant, it was a small amount more, is that finasteride shrinks the prostate. And when you use a standard number of needle cores to biopsy, let's say 12 needle core biopsy, or I think they did 6 core biopsies back then. Let's say on 100 cc prostate, what's the chances of finding a Gleason 9 in a 100 cc gland, whereas someone who's taking finasteride, his gland has shrunk down to 50 cc's. And so you have a smaller target and you get better chance of finding what's there in everybody. There's higher grade amounts of cancer lurking in all large groups of men. So anyway, it's finasteride isn't going to kill anybody. It was touted as a anti-cancer treatment early on when we had very few tools back in the 1990s. It has its place. I mean, it cuts down on hair loss on our scalp. It sometimes improves urinary symptoms, but as an anti-cancer treatment, I don't think it has all that much efficacy. And as a source for causing bad cancers, that's ridiculous.
Phil in Toronto wants to know, why did you adopt all these different colors of blue as your staging flags?
Sure. The reason was to try and get away from the standard terminology, which scares everybody to death. When we see newly diagnosed patients, literally when I see them for the first time in my office, many of them are shaking in fear. They are so terrified by the whole spectrum of dealing with prostate cancer. They think they're going to die. They think they're going to have their prostates cut out. They are so frightened. And so we use this terminology of high risk prostate cancer. High risk of what? Well, actually, it was a risk of possible spread outside the gland, not a high risk of dying. Mortality rates in high risk prostate cancer are very, very low. So we wanted to diffuse some of the fears. I don't see people thinking clearly when they're frightened. People that are frightened are just jump into some imminent treatment, and they abdicate their thinking abilities. So the whole idea of the color system was to try and create a less threatening paradigm.
Should those initially in teal shout I don't understand the word shout, but should those in teal consider a pylophorite scan to make sure the disease is located? I hope I pronounced that right. PYLARIFY.
So that's the proprietary name of the PSMA PET scan that we were talking about off and on through the talk tonight. And so the answer is people that have the higher grade forms of teal, say the basic and the high teal, as we subdivided this intermediate risk category, should definitely consider getting a PSMA PET scan to ensure there's nothing outside the prostate, and also to, if they're thinking of focal therapy, to make sure there's no cancer on the apparently clear side of the gland.
Excellent. Here's a question from Michael that I'm going to summarize. Basically, since the technology with things like HIFU and Tulsa Pro are improving all the time, what should we do? Should we hold out for less invasive, less side effect causing treatments? And I hope I summarized Michael's question correctly.
Well, I think that's one of the attractive benefits of active surveillance, is that you can postpone what so-called modern treatment with all its pitfalls, and possibly grandfather into future treatment that is equally effective, more effective, and less toxic. So yes, I think procrastination is a good thing as long as people aren't taking unnecessary risk. And we can identify that risk now by looking at accurate scans, accurate biopsies, and we can predict who's likely to have problems with great degree of accuracy. And that's the beauty of modern medicine, is we're not guessing. We're actually using large databases to compare people to many thousands of men that have gone before and successfully pursued active surveillance or focal therapy.
Francis says you consider SBRT CyberKnife a radiation treatment. That's worth having. Can you explain why it's being promoted as a focal treatment? And I thought it was available both as a focal and a whole gland treatment.
Any treatment can, in theory, be done focally. When you're thinking of doing focal therapy, I'm less concerned about the type of treatment, and I'm much more concerned about the doctor who's aiming the treatment. So treating the prostate is already tricky. It's a small target buried inside your body with a lot of sensitive things immediately adjacent, like the bladder and the nerves for erections. So doing focal therapy is an even smaller target, and so requires even greater precision and skill. So I would rather have someone use the wrong tool, but they themselves are talented, accurate, and experienced people. So I think any beam radiation can certainly be used for focal therapy, but more importantly are you the first one that they've practiced on, or is this someone that's doing this as a normal course of their ongoing profession?
A question from Michael. Now that we have new, better diagnostics, how quickly will the standard practice change to take advantage of these new diagnostics? And it's sounds like a compound question. Will lutetium PSMA be approved for castrate-resistant metastatic PC? If so, will there be a liability problem for using lutetium for non-castrate resistant PC? So I think it's a
Well, I think that's an easy one. I mean, there's 1.5 million lawyers in the world, in the United States. They have to make a living somehow. So yeah, there will always be liability.
Okay. Let's see what we can find here. It looks like there's a lot of question and answer inside of our chat tonight, which is unusual.
That's my fault.
It's not hard. I'm just looking for the questions for Dr. Scholz right now. Okay, here's one again from Francis. Dr. Scholz, would you please comment on the degree of discomfort associated with the placement of seeds in the perineum? And I see TIA here, and that's a question I've had because I've heard urinary urgency is one of the side effects of seeds.
Yeah, we addressed that. We called it urinary bother in the slide that was presented tonight. Urinary urgency is one component of urinary bother. Another component of urinary bother is going frequently. Another component is waking up frequently at night. So these are certainly are risks of all types of radiation, including seed implants. And there's actually a doctor at UCLA, Joanne Wiedhouse, that has developed a genetic assay to predict who is more likely to develop that type of toxicity. So the risk is relatively low, less than 5% or so. But if you're the 5%, it's really a problem, and you're thinking about your urination all day long. So so yes, this is one of the risks that has to be calculated when considering your options.
Tommy has had an interesting situation. He had one institution read his Gleason as 4+3, basically one core of 12, original 4+3. I think there's a parenthesis 7 at 42%, and then he sent it to Johns Hopkins. And Johns Hopkins found 4+4 parenthesis 8, 50%. With PSMA T2M 0N0, and then he wants to know, could he fight for focal treatment rather than going in for surgery or perhaps some non-focal radiation?
Well, let's summarize what he's saying. What this person is saying is he has a high-grade tumor that's localized in one side of the gland, and the question is, can you do focal therapy? I think you can do it with a lot greater confidence now that we have PSMA PET scans that can show two things. One is the absence of cancer on the other side of the gland, and the other is the absence of any metastatic disease. So people that have localized high-grade disease are, in my opinion, candidates for focal therapy.
Very interesting. Let's go on to Lou. Looking at PSA drop while you're on finasteride, how much does finasteride drop PSA?
Well, the general rule of thumb is that men that don't have cancer will have about a 50% decline in their PSA on finasteride. That's an average of a group of men that go on finasteride. And any single individual, it may cause no decline of PSA or even more dramatic declines. But the average is about a 50% decline.
Does it stay at 50%? I notice all kinds of weird things with my own PSA from 3-month draw to 3-month draw. PSA is so frustrating, not only for the amount of artifact involved, but to know if it's coming from cancer, maybe my gland is getting bigger in spite of finasteride.
Well, I think it's good that you're making that point, as people tend. At one time, PSA was all we had, and we were trying to squeeze every drop of information out of it that we could. Now we have much better tools, imaging tools that previously were unavailable. But if you look at the accuracy of, say, getting an MRI at a quality center compared to what PSA can tell you, the MRI is probably 30 times more accurate as to what's going on than the PSA. So does that make PSA useless? Well, think of a day when we didn't have MRIs. PSA was the only window we had into the prostate other than doing biopsies. So PSA was greatly revered, and it was utilized even despite its many weaknesses. So it's now I think PSA is more like the backstop in a game of baseball. You don't incorporate that into your game plan. We'll just let the ball roll to the backstop. but it's nice that it's there if, rather than letting the ball go all the way to the parking lot, if it goes between the catcher's legs. So PSA has a role, but most people tend to overemphasize it based on its historical, historically only being the only thing we had.
Excellent. Steve, again, why not has transrectal anterior zone biopsies been standard practice given its accessibilities?
Couple reasons. One, now with MRIs, we can see the front of the prostate accurately. And if you have a choice between getting an imaging scan and having someone harpoon your butt with a large bore needle, I think you probably prefer a scan. The other reason is there have been a lot of studies done where they've looked at random biopsies with or without transition zone biopsies, and they've shown over and over that it changes the outcome by 1 to 2%. And so it just doesn't have much yield.
After recurrence, post-surgery, and a PSMA PET CT scan, does an MRI in addition add any information? In other words, should we be layering up MRIs with PSMA PET scans in making future treatment decisions?
After surgery, probably not going to give you much information. After radiation, perhaps you get some definition inside the previously treated prostate gland with MRI that's complementary to PSMA. PSMA is pretty good inside the prostate after radiation. MRI gives a sort of a second opinion. So PSMA MRI scanners are starting to be developed for this reason. After surgery, there's no prostate left to scan. And so I don't see much point in doing an MRI if you're going to have a PSMA scan.
Here's one from Aaron, and it's one that Dr. Lamb helped me answer. Is genomic testing appropriate for 3+3 Gleason 6 stage 1 cancer?
No. The reason is that all the active surveillance data was developed based on Gleason scores and biopsies. The genomic testing is a useful test, in my opinion, for when you need a tiebreaker, when you've got a little bit of 4 and you're trying to decide if it's likely to spread outside the prostate. The trouble with genomic testing, like any testing, it only gives you a statistical projection. So 1 out of 5 cases, it's actually giving you inaccurate information. And so you can take someone who's perfectly acceptable for active surveillance with pure 3+3 and scare them to death with a genetic test that is actually wrong, just because of the statistical variations that are contained in this type of testing. You say, well, why is it useful for anything then? Well, the answer is that when you have someone who's sitting on the fence, not certain which way to jump, at least with a genetic test, you'll have a 4 out of 5 chance that he's getting good information. It's not bad. But if someone already knows they're a good candidate for active surveillance, I wouldn't mess with success.
Okay. Let's see what else we have here. We have something from Nancy. Is the Decipher test similar to the Oncotype test? Is one better than the other for assessing risk and aggressiveness?
Thank you, Nancy, for asking that question. In my opinion, from what I've seen over and over with the Decipher test, is an excessively grim and negative outlook about the possibility of watching. It's sometimes shocking to me that men with pure 3+3s will get, 15% risk of metastasis at 10 years. Absolutely ludicrous things for the Decipher test. So I don't order a Decipher test for that reason. I think all of the genetic tests tend to be somewhat pessimistic because they're based on 10 to 20-year-old databases. You can't get 10-year outcomes unless you go back quite a ways in time. These people were not monitored with MRIs. They were monitored with random biopsies. So that the numbers that you get, the projections you get from genetic tests are going to tend to be pessimistic. But it seems like the least pessimistic of the 3, there's Prolaris, Oncotype, and Decipher, is Oncotype.
Ken wants to know, my urologist says PSMA PET is covered only for severe prostate cancer cases. Is this true?
Not in my experience. It's only covered so far, it's only been FDA approved for 90 days or whatever, or excuse me, Medicare approved for 90 days or so. In our Medicare patients, we're really not seeing much of any restriction in the application of the PSMA PET scan for men that have a diagnosis of prostate cancer of any type. We're seeing a lot of problem for people that have Blue Cross, Blue Shield, private insurances to get any kind of PSMA PET scan done under any circumstances.
Okay. Michael wants to know, there seems to be a trend towards transperineal rather than transrectal. Okay, we answered that question. What does a patient have to do to get Medicare approval for a PSMA scan? Can Gleason 6 patients hope to get that paid for?
In our experience, they have, yes.
Okay. Michael, again, how would you proceed with a patient that has had surgery or radiation and has a stable PSA 1 or below that starts increasing PSA? Where would you start doing something? I think historically urologists wait for PSA to get to 5 or earlier with PSMA PET scans now. How would you proceed with treatment?
Well, we believe earlier rather than later. So people that have had surgery, we start doing PSMA PET scans if the PSA goes above 0.2. In people that have had previous radiation, we'll start doing PSMA PET scans if the PSA goes above 0.5.
All right. Rich wants to know, what's your thoughts about theranostics?
What are my thoughts about theranostics? I think that they're one of many useful areas of development, and we're hopeful to see more and more of them.
Okay. Nancy again, does the presence of intraductal carcinoma with a 3.4 cancer argue against focal treatment?
No, doesn't argue against focal treatment.
Okay. So there's a question about brachytherapy. So HDR brachy can be used focally? Joe Gallo wants to know.
Yeah, we do it all the time.
All right. Ira Caggett, why are urologists locked into random biopsies and not MRI fusion or micro ultrasound? What can we do to change this?
Well, when I got into the prostate business 25 years ago, I was shocked at the stranglehold that the surgeons, the urologists had in the field of genitourinary cancers, and I thought, wow, this is so ridiculously unbalanced and strange that this is unsustainable. That was 25 years ago.
And they've succeeded in sustaining it?
I don't see any diminished energy to continue their absolute monopoly on this area.
Mark wants to know, would you ever repeat a PSMA PET after treatment with radiation if PSA is low?
How low? There's just a lot of variables there. But the answer is that all the reasons that we used to do scans, bone scans, CAT scans, MRIs, every motivation for doing those scans was to try and get useful information to help decide where we stand and what we need to do. If people have access to a PSMA PET scan, they're not going to be doing any of those other scans anymore. The PSMA PET scan performs in every regard far superior to all the other scans that we've had before. Far more specific, far more sensitive, far more consistent, far more accurate. So people that are doing bone scan and CAT scans, I just take the reports and throw them in the trash, and I order a PSMA PET scan.
All right. Any other questions before we say goodnight? Michael, regarding PSMA PET scans after surgery or radiation, on rising PSA, what things might you see and how would you treat these various situations?
Well, we know that prostate cancer, with PSMA PET scans, we're detecting metastases at their very earliest stages, something that we've never been able to do before. And not surprisingly, therefore, what we're finding is that people tend to have early spread to 1 or 2 pelvic lymph nodes. I am very hopeful that since we're discovering this spread at such an early stage, that many of these very early metastatic patients are going to be curable.
Francis, my question is about the discomfort associated with seed implants. Kind of got lost in another part of the answer. Francis, would you like to unmute and ask your question and see if we can clear it up? Francis? I'm going to move on for now. Would the UroLift interfere with any scans?
That's a good question. See if I think I might have a copy of my book up here. I'm going to show my book. You see it up there anywhere?
Not anymore, but I see the key.
I'm not seeing a problem. You can get some artifact with UroLift after MRIs, but it doesn't seem to be a big problem at all.
All right. How would you view TULSA-PRO for full gland treatment, especially where there is noted cancer near the edge?
I think that it's got intriguing possibilities. Reason I haven't referred a lot of people for TULSA-PRO is it's not covered by insurance and it's quite expensive. And the other reason, of course, is I haven't had enough patients that have had the treatment with, coming back with smiles and satisfaction and, good erections and no incontinence. The claims of the company and the preliminary findings look pretty encouraging, but other existing forms of therapy, which are more established, are from where I sit, safer options right now until we see more experience with it. But I think on paper it looks pretty good.
Before I conclude, I'm going to let Francis ask the question about discomfort and brachytherapy. Are you in? You're
Yes,
ready to go, Francis?
I'm here, Neil. Can you hear me okay?
I hear you fine.
Great. I just wanted to ask Dr. Scholz about the degree of discomfort associated with placement of the seeds. I've heard on some forums it's worse than transrectal biopsy.
I think when people go through, of course, there's 2 types of seed implants. The temporary seeds where they put the catheters in and they dwell in the body for 10, 12 hours or something like that. And then you have them taken out and you go home from the hospital. And then you have the permanent seed implants where it's like a 45-minute outpatient procedure. So I think you're referring to the temporary seed implants where the patient's in the hospital for, 8 to 24 hours with the catheters hanging out of his perineum like a porcupine. And the answer is yes. In some individuals, it is very uncomfortable. It doesn't seem to be a dominant complaint because I've had, hundreds of patients treated this way. And it is, but there are occasional patients who find it extremely uncomfortable. I'd say about maybe 5% of the patients. It's like, what have you guys done to me? But like having a child, after the terrible misery is over and the patients go home and they do well and they get cured, some of the horror is forgotten. But yes, I think temporary seed implants have a potential to be very, very uncomfortable in a small minority of patients that are undergoing the treatment. Talking about the administration of the treatment itself, not the sequela of the radiation.
Exactly. And thank you so much for the clarification.
I think I'll bring the meeting to a close. I want to thank you again, Dr. Scholz, for joining us. We always enjoy your presentations, whether they're here or at PCRI, and look forward to you visiting us again. Next month, drop by on March 24th at 7 p.m. For Bernadette Greenwood of Desert Medical Imaging, especially if you have questions about the application of imaging and treatment, you'll want to be here on March 24th. Thank you very much, Doctor. We look forward to seeing everyone.
Thank you so much for having me. You guys run a really good show. Thank you so much.
Thank you. And we'll look forward to seeing you all next month.